Good evening and welcome to this meeting of the Commonwealth Club of California, the place where you're in the know. You can find us online at commonwealthclub.org, on Facebook and Twitter, and on our YouTube channel. I'm Dr. Alice Chen, Associate Professor of Medicine at the University of California, San Francisco, and a primary care provider and Chief Integration Officer at San Francisco General Hospital, and your moderator for today's program. So, in March 2010, the Affordable Care Act was signed into law. It was the most radical restructuring of America's healthcare system since the creation of Medicare in 1965. The ACA was controversial and highly political, faced legal challenges reaching all the way to the Supreme Court, and even precipitated a government shutdown. It was arguably President Obama's signature piece of legislation during his first term. Our guest, Dr. Ezekiel Emanuel, has been called an architect of the ACA and became a target of political controversy himself as the act became law. A bioethicist and breast oncologist, Dr. Emanuel is Vice Provost for Global Initiatives and Chair of the Department of Medical Ethics and Health Policy at the University of Pennsylvania. In his new book, Reinventing American Healthcare, Dr. Emanuel offers a comprehensive overview of American healthcare, an insider's analysis of the politics behind the passage of the ACA, and a vision for what healthcare will look like in our not-so-distant future. So please welcome Dr. Ezekiel Emanuel.
Thank you. It's a great pleasure to be here at the Commonwealth Club again, and to be in San Francisco again to talk about healthcare and healthcare reform. Let me begin with a short trip down memory lane. I know that 4 years after passage of the Affordable Care Act, there are a lot of people in the country who have a hard time remembering why we actually passed the act. So it's worthwhile going back to the period of 2008, 2009, where the presidential election was about the collapsing economy at that time because of the Great Recession. But second topic in that campaign was healthcare and healthcare reform. One reason we needed healthcare reform is the fact that we had reached the point where about 50 million people in America did not have access to health insurance. 38 million of those citizens of the United States and about 11 or 12 million undocumented aliens in the country. We had consistent and persistent quality problems. Great institutions like UCSF and other academic centers delivering unbelievably great quality, the envy of the world, but a lot of other uneven quality, lots of hospital infections, medication errors, and other complications and problems that made the system not something we could be very proud of. And probably the biggest problem was runaway costs. For 50 years, the healthcare system had grown larger and larger, much larger than the whole economy, consuming about 18% of GDP. That is, $1 out of every $6 in your wallet going to healthcare. Now, a lot of people have no idea how much we spend on healthcare or don't have a context for it. This last year, 2013, we spent $3 trillion on healthcare. Now, you guys are very smart, but it's very hard to understand that big a number. So to put it in context, the French economy, everything for the 66 million French people, $2.58 trillion. In other words, the American healthcare system is the 5th largest economy in the world, larger than the French economy. Only the German, Japanese, Chinese, and American economies are bigger. That's a huge amount of money, and it's going up faster than the growth in the economy. And that was creating huge numbers of problems. For one thing, wages had been flat, in part because so much money was going to health care out of total compensation. Lots of state budgets had problems because Medicaid was going up, and cuts had to be made to things like primary and secondary education, and especially public universities and colleges. And the federal deficit. The long-term projections for the federal deficit were all dire because of healthcare reform. So we had good reasons from the access standpoint, the quality standpoint, and the cost standpoint to reform healthcare. Another point I want to emphasize is President Obama had a plan, but he did not have all the details worked out, and he left a lot of that to Congress. We spent months and months trying to make this bill a bipartisan bill. Many of you will remember something called the Gang of Six. Senator Max Baucus, who was chairman of the Finance Committee, which wrote a large part of the bill, he held numerous meetings with Republicans trying to get this to be a bipartisan bill. My boss, when I worked at the Office of Management and Budget, Peter Orszag, was a special go-between with Senator Olympia Snowe, a Republican of Maine. He had a special relationship with her. He would go down, talk to her. She would have a list of things that she wanted in the bill. He would come back, and myself, along with several other people in OMB, were sort of tasked to make sure that we could put these in the bill, or if there was something we couldn't put in the bill, there was a pretty good reason he could go back to her with. And this went on, and we accommodated all of her requests. And she actually voted for the bill coming out of the Finance Committee. But when it got to the floor of the Senate, she did not vote for the bill. Now, legislation, as you'll all appreciate, is a very complicated thing. I've said this many times, but there is no piece of legislation coming out of Congress that will be perfect. I would actually say there's probably no piece of legislation coming out of any democracy that's going to end up being perfect. There are all sorts of compromises, issues that have to be worked out that turn out to be, from many people's perspective, less than optimal. Let me just give you one story about something that I know lots of people, especially if you're in healthcare, sort of concerned about, and that's medical malpractice. Now, this is a big preoccupation for doctors. Before I talk about it, I just want to remind people that medical malpractice is largely a state issue. It's regulated largely at the state. So to put something into a federal piece of legislation, at best we could have encouraged the states to change or provided them incentives to change. Nonetheless, the Affordable Care Act provided a very unique opportunity for medical malpractice reform. Unbeknownst to many people, the president, when he was a senator, actually had introduced a bill on medical malpractice reform and wrote an editorial in the New England Journal urging medical malpractice reform. So he was very much supportive of this idea. I, as a physician in the White House, the other physician working in the White House on healthcare reform, Bob Kocher, who now has moved out to California, we were for medical malpractice reform. People like Larry Summers and Peter Orszag, my boss, were for medical malpractice reform because they saw this as a way to change incentives and to really have doctors focus on higher quality care. And all of us knew that the current system, that the malpractice system as of 2009 was not functioning very well, whether for the doctors or the patients or just a way of improving quality. So we were actually tasked with working up some proposals and alternatives and studying the whole system, and a small cabal of us worked in the White House on a memo trying to delineate things. One day in the summer of 2009, I wandered into my brother's office, the chief of staff's office. He had regularly tasked me with thinking about various things on healthcare, thinking about alternatives, run some numbers there, tell me what it'll cost. And, so I went in towards the end of the day, which was my usual approach, just to talk with him how things were going. And I walked in, and one of the things that's true about my brother, growing up, he was an absolute slob. My father used to say, he'd have to go into his room in the morning and look under all the mess to try to find out where Rom was. Well, as he's grown up, he's become obsessively neat. He never left the office in the White House with a piece of paper on the desk. And at this time, towards the end of the day, he had simply 2 pieces of paper. He was standing up and looking down at those pieces of paper, and he said, how are things, Zeke? Did you get me whatever I was supposed to work on? And I explained to him that we were in the process of running the numbers, and he says, how's everything else? And I said, well, I've been working on this medical malpractice, and he just cut me off. He said, shut the blank up. We're not doing that. Because every time the doctors come in, they don't talk to me about malpractice. 1, 2, 3, 4 is fixing payment to them SGR. I'm not alienating the president's base for no reason at all. And that really told me everything I needed to know as to why medical malpractice ended up not being a big part of the bill. First, there were no Republicans who were going to come to the table, and they could have said, you know, we wanted medical malpractice important to us. This is a condition of our signing on to the bill, and negotiate about it. But they weren't going to do that. And the doctors, if they had said, we need to have medical malpractice in the bill for our support, would have been in the bill. But that wasn't what they were concerned about. And the politics just did not line up for that. Nonetheless, the president was extremely committed to medical malpractice reform. And some of you may remember in his September 2009 speech, he talked about a proposal. We developed a proposal to give grants for experiments how to improve the medical malpractice system. And actually the bill, the Affordable Care Act, has a provision that incentivizes states to try new ways of doing medical malpractice reform. So the president's actually done more on medical malpractice, but it's not a comprehensive reform, and that is because of the politics I just mentioned to you. Many of you will know that we spent the year working hard. The bill had passed the House, and on Christmas Eve, 2009, it passed the Senate, and then disaster struck. Scott Brown was elected in Massachusetts to Senator Kennedy's seat, and the 60-vote lead the Democrats had to prevent a filibuster of the bill had disappeared. And the only way to get the bill through was for the House to adopt the Senate version of the bill, much to their chagrin. And it took about 2 months of going back and forth for them to come to that and finally vote on it. It is a minor miracle that the bill passed. In the United States, we've been trying to reform the healthcare system, get comprehensive healthcare reform for 100 years, since 1912. And my book details some very interesting historical precedents. So let me tell you briefly about one, and then we'll shift to how the Affordable Care Act is changing the system. There had been a proposal in Congress for people to buy private health insurance, recognizing that many people could not afford private health insurance, that the federal government would subsidize people for their purchase of private health insurance, and that subsidy would be linked to income, and so that the poorer people were, the more subsidy they would get. Does that sound familiar to anyone? Right? That's actually Richard Nixon's proposal from 1950. And the only big difference between that proposal and the Affordable Care Act is a mandate. He thought voluntary insurance could work. He got educated out of that. By the 70s, he recognizes it needed to be mandatory. Pretty incredible that often the Republicans had proposed a plan not too dissimilar from the Affordable Care Act. In fact, the Affordable Care Act has its origins, the individual mandate, the exchanges, the competing private insurance companies, with proposals from the Republican side, from the Heritage Foundation, actually. Well, as Dr. Chen mentioned, the Affordable Care Act is a comprehensive redoing of the healthcare system. It's useful to think about the fact that 4 years ago it was passed, and it's already had a dramatic effect. On the access side, 8 million people have got coverage through the exchange. Another 5 million, roughly, have bought policies in the individual market. Another 3 to 5 million have gotten Medicaid expansion. 3 million people have gotten coverage, young adults under 26 have gotten coverage in their parents' plan. The estimates are between 9 and 12 million people who got coverage in this period didn't have insurance before. And the Gallup poll, which has been tracking uninsured rate, has seen since the end of last year, 2013, a steady, persistent decline in the number of people uninsured. The 8 million number tells you a lot. For 2 months, the federal exchange was down. Now, the California exchange was one of the best operating exchanges in the country. But for 2 months, there was no access to the federal exchange. The original projection was 7 million people would sign up. 8 million people did, despite the fact that they could only do it in 4 months. It tells you a lot. It tells you that Americans really want affordable health insurance. that many of those people who were uninsured, it's not because, as some people would say, they liked being uninsured and being rough individualists. No, they just couldn't afford insurance. And when given an opportunity to buy affordable insurance without pre-existing condition exclusions, they gravitated to it. I think that portends a very, very vigorous use of the exchanges for the future. On quality, there's been a number of improvements directly related to the Affordable Care Act. The bill has some provisions to reduce the readmission rate to hospitals. Prior to passage of the Affordable Care Act, if you were a Medicare beneficiary, you had been admitted to the hospital, your chance of returning to the hospital after discharge was 20% in 30 days. 1 in 5 people returned to the hospital. Well, the bill had a penalty for hospitals that didn't reduce their readmission rate, and it has steadily declined, and I think it's going to steadily decline into the future. Part of the bill was improve the quality of care. And we created in 2010 something called the Partnership for Patients that incentivized 3,700 hospitals in the country to reduce hospital infections, medication errors, falls, and a whole series of other things. And the 3-year evaluation showed that across the board, these hospitals reduced those errors 9%, and in some particular areas like ventilator-associated infections or intravenous central line infections or elective early C-sections have dropped over 40, in some cases over 50%. Real big improvement in quality. And on the cost side, we have seen a moderation in costs. Some of that's due to the Great Recession. Some of that's due to restructuring of how much deductibles people face. But some of it is certainly due to the Affordable Care Act. Now, we can't rest on our laurels. We have to push on. There is no crossing the finish line, solving the problem. The subtitle to my book is How the Affordable Care Act Will Improve a Whole Series of Problems of the System. I don't say it will solve. It will lead to improvement. We are going to constantly be needing to attend to the healthcare system. It is a $3 trillion business, the 5th largest economy in the world. There is no we're done. We're constantly going to have to be working at making it improvement. Continuous improvement is part of the system. Well, at the end of the book, I make a number of suggestions for what Healthcare Reform 2.0, what are the things we could do today to improve the Affordable Care Act. Probably my biggest disappointment in the bill is we didn't have enough payment change. The current system pays doctors fee for service, largely, and hospitals fee to do more. And the consequence is we have a sick care system, not a health care system. If you're paid to take care of sick people, you're paid to operate, you're paid to do things for them, it's no surprise, you do a lot of things for them. And if you're not paid to keep them healthy, you don't really focus on keeping them healthy. We need to change that incentive. And one of the things I'm disappointed about, and I talk about why in the book we don't have more of it, we need more payment reform. We need to move that along quicker to incentivize the whole system to keep people healthier. That is going to be the major way of improving the quality of care and reducing the costs over the long term. And the last chapter, I look over the time horizon to 2020 and beyond. And I make 6 big megatrend predictions. I'll just go over them briefly, and we can talk about any one of them that interests you. The first one is, I think there is going to be the end of insurance companies as we know them. The idea that big insurance companies take in premium and pay doctors and pay hospitals, I think, is going away. Over the next 10 years, we're going to have a convergence where big health systems are going to actually take insurance themselves, become much more integrated delivery systems, integrate across the continuum of care, but also integrate with the insurance function. I sometimes call this the Kaiserification of American healthcare. And insurance companies are similarly going to partner with providers or employ providers, employ health systems, and provide the continuum of care. And so you're going to see these 2 groups, health systems becoming more like integrated delivery systems and insurers becoming more like integrated delivery systems, and everyone competing for either employer contracts or people in the exchanges. And we will not have what we have hitherto known as the traditional insurance company. Second, I think, as I've mentioned, keeping people healthy is going to be key to saving money. And so the key way to keep people who use a lot of resources healthy and to keep the quality of care they get up is to really focus on those people who use a lot of resources. Those are the chronically ill, people with heart disease, with emphysema, with diabetes, with hypertension, asthma, cancer. So we're going to see a blossoming of care focused on them, VIP care focused on these people, to keep them healthy, keep them out of the hospital if they get sick, treat them more at home, and we're going to see a lot of innovation in this space. I actually think we're going to have a shift of more people to exchanges and off employer-sponsored coverage, which I think more people will like. Many people who have employer-sponsored coverage, actually the majority of people who have employer-sponsored health insurance, don't actually have a choice of insurer at all. They're told by their employer what they get. And if they switch jobs or start their own company, they have to switch insurance. In the exchange, they get to decide among a large variety of plans, and they don't have to switch coverage, switch doctors when they switch jobs. I think actually we're going to do a lot better on healthcare inflation, especially if we change the payment system and doctors and hospitals focus on keeping people healthy. I'm predicting by the end of the decade, healthcare inflation coming down to the rate of growth in the economy. That'll be good for all of us. That'll allow states to focus more money on education. It'll actually mean that for most of us, we'll see bigger pay increases. Probably my riskiest prediction is about the reform of medical education. When you have a big transformation of the health system, you really have to change how we train doctors, nurses, and others. Unfortunately, most medical schools are pretty slow evolving. We're still training doctors essentially in the same way as the Flexner Report in 1910 suggested. 2 years of preclinical work, 2 years of training in clinical medicine in the hospital, then you do internship and residency. But we have to completely change that. Needs to be more team-based training. We need a lot more training in how to use data and how to manage teams. We need a lot more training in actually caring for patients out of the hospital, because I think a lot of hospitals are going to, a lot more care is going to be delivered out in the community with the rise of monitoring and wireless devices. We need a very, very important change in our educational system. But the last thing I'll say is, for a lot of people, the change sparked by the Affordable Care Act is causing anxiety. Certainly true in the medical profession, and a lot of people is, what is it really going to mean for me? We also should look at this, though, as a great opportunity. This is a restructuring of the system. It's a restructuring of the system away from a sick care system to a health care system. It's a restructuring of the system away from delivering care in hospitals to delivering care where patients live. And all of that is going to be much better for us. In the end, the Affordable Care Act is going to lead to a much consistently higher quality care at a much more reasonable price for all Americans. That is something to be proud of. Thank you very much.
Great. Thank you, Dr. Emanuel. This is a reminder for our radio audience. This is the Commonwealth Club of California program. We are talking to Dr. Ezekiel Emanuel, Vice Provost for Global Initiatives and Chair of the Department of Medical Ethics and Health Policy at the University of Pennsylvania, and author of a new book called Reinventing American Healthcare. I'm Dr. Alice Chen, your moderator. You can hear Commonwealth Club programs on the radio, catch up with us on Facebook and Twitter, and see program videos on our YouTube channel. Great. So, you were mentioning that this question comes up in every single conversation about your book, so I'll have to start with that. Okay. So I neglected to mention that the subtitle of the book is How the Affordable Care Act Will Improve Our Terribly Complex, Blatantly Unjust, Outrageously Expensive, Grossly Inefficient, Error-Prone System. So my question is, has anyone ever accused you of mincing words? No.
Well, I'll tell you, the reason for the subtitle is that I've been frustrated by all these books that have single word titles, habit, simple, switch. And I said, why don't we just go back to Jonathan Swift, where the title tells you the whole book, and it's basically the summary. My publisher said, no way, you'll just never, no one will buy a book that's got 19 words in its title. So I said, well, I need to have that as the subtitle. So
Well,
that's
it's always
why.
the good beginning of a discussion. But in all seriousness, I think that characterization of the healthcare system very much resonates with many people who work in healthcare. And at the same time, you look in newspapers, and every day on the front page, there's a breakthrough on this, an amazing discovery on that. And a lot of Americans feel like we have the best healthcare system in the world.
So
How do you reconcile that?
we need to differentiate the care that some people can get, which is or can be the best in the world, from having the best healthcare system in the world. We clearly don't have the best healthcare system in the world, and no one who, on any metric, would argue that we clearly have the best system. So, again, on an access metric, covering people, we don't have the best system. I note in somewhere in the book, in the campaign, Governor Romney said, well, no American died because they didn't have health insurance. They can always go to the emergency room. That turns out to be blatantly wrong. There's a lot of data that if you don't have health insurance, you actually do get worse care. Certainly in my area, cancer care, that's been true. And you do have a higher propensity to die. If you just look at the 5-year survival rate among cancer patients, those people who have private insurance do substantially better than those people who are uninsured. Another researcher looked at what happens to people in an emergency once they've had a car accident. Well, it turns out, you would think car accident, an emergency, who cares about insurance? Well, it turns out that your insurance status makes a big difference as to whether you live or die and how you're treated. So not having access, that's also bad. It just doesn't mean people don't have they have to pay more bills. It means that, they literally could live or die. Similarly, this quality problem, it is true. At the tippy top, the institution you work for, the institution, yes, you can get great care. But it's very uneven. We have millions of people in this country. Simple thing, hypertension. Either they're not diagnosed with hypertension or it's not well controlled and they're at increased risk for heart disease and strokes. That's not good quality care. And lots of people have done studies and looked at, how good is the care across the board, on average in America. And, the chance you're going to get proven care that's proven to extend your life or improve the quality of life, it's about the toss of a coin, a little better than the toss of a coin. How can we be proud of that? And then the cost is surely just outrageous on any metric. But we could go on and on. The one area where we might have a fighting chance for being the best in the world is in cancer care. There's a lot of disagreement about that. But it's at least a plausible argument there. But that leaves vast areas that we can't be proud of.
Right. I think this audience is probably one that very much appreciates a systems perspective and kind of looking at the data. At the same time, as you acknowledged at the end, healthcare is an intensely personal experience. And it actually does engender a lot of anxiety when people think about, how is this going to affect me? So actually, this question from the audience really stood out to me, which is, it really gets to, what does it mean for me? So as a Medicare patient enters a hospital or a doctor's office under Obamacare, will there be any manifest differences in that patient's experience from pre-Obamacare?
That is a good question. So let's talk about Medicare, because one of the things that was true, certainly throughout the time, is that the people over 65 who were entitled to Medicare, who basically have universal coverage for people over 65, were very anxious that this bill was not going to be good for them. So let's just enumerate the ways the bill has improved them. First, on the financial side, this bill has been terrifically important for Medicare. It's extended the Medicare Trust Fund by about a decade, so that actually the amount going in under Medicare taxes can actually support the Medicare bill. The premiums paid by Medicare beneficiaries in Part B and Part D, that's the drug benefit and the outpatient physician benefits, have actually stayed flat, largely because of the Affordable Care Act. So financially, it's actually been a pretty good deal. The donut hole, that famed donut hole in the coverage that was put in financial jerry-rigging to get the bill passed in Congress. That is going to be closed by the Affordable Care Act by the end of the decade, and millions of seniors have actually gotten better drug coverage at a cheaper price because of the Affordable Care Act. And finally, as I mentioned, this partnership for patients, any senior who goes into the hospital, the chance of an infection, the chance of a medication error, the chance of a fall have declined. That's true for not just seniors, but anyone who goes into the hospital. So it's manifestly a better bill for seniors, even though it does nothing for their access. It does a lot for their financial, and it does a lot on the quality of care side of things. So the idea that seniors haven't gotten anything out of this bill is bunk.
So we can actually go in two directions. I'm going to go, since you're in San Francisco, go the logical route, which is why not Medicare for all? We've got a couple questions here about, do you envision ACA as a single payer entity eventually? You know, what are the pros and cons? And at one point you had said it was impossible to scale up for all citizens. But so if, you know, Medicare is robust, why not Medicare for all?
So single payer is not going to happen. And it's just a fact of political life. I like to remind people, I think I reminded people in my prepared remarks, we barely passed the Affordable Care Act. Okay? If you think you're going to pass single payer, let me invite you to Washington and I'll take you around the halls of Congress. There is no chance, no way, no how. Just not happening. And I don't think the Affordable Care Act, despite what some people have said, is a surreptitious way to get to single payer. That's also not happening. Let's just play it out. What do we get out of the Affordable Care Act? We have a marketplace where competition among private companies offering insurance, and soon there are these, you know, like Kaiser, there are these integrated delivery systems. Subsidies to people to buy that private insurance. That is not single payer. It is not a government takeover of healthcare. It's a vigorous marketplace with competitors offering products that people get to choose from. And that, I believe, is going to be a very successful model. It's very American. It's as American as apple pie. And I think it's actually going to be something that is going to be pretty stable because it's going to put some downward price pressure. It's going to give people choice, which is what they want. You'll see quality. So I think actually that's the direction we're going. It's certainly the direction the Affordable Care Act pushes us in. We would need some major hiccup along the way, you know, collapse of some private insurers or no offerings that are not reasonable or desirable by people to, I think, have a major shift. And I just don't see that happening. So I do not see a path from here to single payer, and I do not believe the Affordable Care Act is surreptitious single payer. And by the way, I do think there's an advantage of having multiple insurance companies as well as Medicare and Medicaid. We are in the midst of trying out different ways of changing how we pay doctors and how we deliver care. We don't know the best way. Dr. Chen could probably tell you more than I could about the fact we have to experiment with how to keep people healthy, how to take those diabetics and make them change what they eat and change their exercise pattern and adhere to their medicines. We don't know the best way to do that. And we need a bunch of different ways to test it out, to experiment. And that happens better when you have these different systems trying it out and trying their best ideas. And so I think there is actually a virtue to having a lot of different competing systems out there.
So can we talk a bit about the insurance exchanges?
Whatever you want.
Okay, well, whatever you want, collectively. You called one of California one of the best health exchanges that have rolled out, and in fact, most people here, I think, thought it was a success and rolled out fairly smoothly, and actually shielded us from the rather disastrous rollout from healthcare.gov. Two questions. One is, what do you think accounted for the differences between Covered California and healthcare.gov? And the second thing is, now that it's implemented and people are enrolling, a lot of questions are coming up around narrow networks and this idea of choice. Like, this is supposed to expand choice, but then all of a sudden, oh, my doctor's not in this plan. I can't see my doctor anymore. Why are doctors being rejected from certain plans?
Those are two separate questions, so let's deal with the California exchange. So the standouts in terms of exchanges, California, Connecticut, Kentucky, were really, they did a very, very good job. Not a flawless job, but a very good job out of the box with a very complex task. What was it? Well, part of it is leadership. California had great leadership in Peter Lee, who's a close friend of mine, and we worked together in Washington. They collaborated very well with insurers, bringing them in and asking them to test out the system. They had better contractors, and I think monitored the contractors better. They have a board that allows the Covered California to operate more like a startup entity than like a government bureaucracy. I think all of these elements are very critical. And they also, I think, were modest. They didn't try to do everything right out of the box. They did, as I mentioned, not unlike the Connecticut Exchange, which is also a very good exchange, probably didn't do a very good job around the Spanish language version. I think a lot of people thought, well, you just take the English website and you translate it and that'll be good enough. And it turns out that's completely, totally false. Everyone's learned that to be false, that there are different ways people navigate the system, and you actually need a different website with different architecture. So I think there are a number of things that made the California Exchange. Leadership, CEO, the focus in on not doing too much, the focus in on having really good employees dedicated to a sort of startup mentality. Another thing that has been, I think, is key is outsourcing a lot of the elements and riding those contractors very hard and keeping a tight rein on them. We've seen a lot of bad contractors out there. I am in San Francisco, but Oracle did a very poor job in Oregon, for example, whereas many people note that Deloitte did a much better job working closely with the insurers. So I think there's a lot we can learn. Again, one of the important things to keep in mind is you can't build it and walk away from it. The work just starts. Different challenges now going forward. Getting all the people who signed up, the more than 1 million people in California who signed up through the exchange, renewing, going to be a big challenge. Getting better product out there, making sure you have the best kind of insurance programs out there, and making sure that people find them good, being able to rate them, being able to figure out who's in the network, who isn't, what the copays are. All of that posing, I think, big challenges, and it's going to require a lot of work to keep going. As I like to say, it's not like Zappos put up their website, said, oh, wow, we have the greatest website, we can stop, right? They're constantly tinkering with it, what they sell, how people navigate, where are the hiccups, and trying to smooth it out. And one of the problems which is true of most of the websites is actually shopping takes more than 30 minutes. Well, I think you got to try to get that time closer, under 30 and closer to 20 for people to really, that's the uncomplicated cases for people to really use it. Let's talk about narrow networks. This is something that causes a lot of anxiety. I'm actually, I think narrow networks can be a really good thing for people. So if you think about care going forward, and you think about these integrated delivery systems, what we're going to evolve to is that you are going to go to a delivery system, and they are going to provide you the comprehensive care, the continuum of care you need, and assure the quality of it. Why are we very focused on the narrow networks now? Because we have no way of being confident of the quality of the narrow networks that we have. We want a broader network as a kind of like, well, if something goes wrong, I can always choose and go outside. If we had confidence in the quality of the network, I don't think the narrowness would be as big a challenge for us as possible, as it is today. As we go forward, we are going to begin, I think, having choices among health systems. Kaiser, I think UCSF is probably, like many academic centers, looking at offering itself as a comprehensive system. Certainly, this is true on the East Coast. In Boston, Partners, that's the Mass General and Brigham, they next year will be offering a Medicare Advantage plan and basically saying, you sign up for us and we're going to provide, we are the network you're in, we're going to provide all that care for you. Mount Sinai is doing the same thing. They're going to test themselves out in Medicare Advantage, and then soon they're going to offer themselves on the exchange and directly contracting with employers. Well, is the Mass General network, does that make people nervous? Probably not. They have faith that it has high-quality care, that they'll be in a very good system, and they can trust the doctors. So I think this issue of narrow networks is really, well, I'm not sure about the quality, and I'm not sure I can trust them. I think as we go forward and have better assessments of quality, and we recognize the networks more as ones we can trust, I think we're going to see that. You know, I'm sure there are complaints, but most people who are in Kaiser, they have a very narrow network. Mm-hmm. It's a closed network. You don't hear tons of complaints. Similarly, group health in Seattle, same thing. You don't hear tons of complaints, well, I'm stuck in group health. You signed up for group health, and they provide the continuum of care, and you're very confident in their quality. And that's true for lots of other places around the country. I was just in Madison, Wisconsin with the Dean Clinic. They don't provide everything. There are some high-tech types of services like cancer treatment or bone marrow transplantation or solid organ transplantation. They don't do, and they send to other organizations. But they provide the continuum of care, and people are generally, you know, it's been rated consistently 5-star, and people are very happy. And I think that's the place we're going to go to. And this sort of narrow network debate is a transition debate.
That's a really good point. We're going to shift a little bit. There are actually a lot of questions here about cost control, price, payment reform, affordability.
Yeah.
How do we get patients engaged and invested in costs? And I just want to put out there, last week I had 2 conversations with 2 separate colleagues on 2 different coasts, and they both were lamenting the fact that they have one foot in fee-for-service and one foot in value-based payments. And in one big institution on the East Coast, 1/3 of their patients are tied to risk-based payments, but it's only 5% of their revenue. Yeah. So how do we actually, it's a great idea, how do we actually make it happen? How do we make the transition? And will those payment models and payment reform actually result in affordability and cost control?
So this is a common problem. We're at about 85%, maybe a little lower now, of payment and fee-for-service, and we're trying to shift to alternative payment models, whether they're bundle payment, paying for the full episode of care, one price, or capitation, saying, here's the $6,000, you're taking care of the patient for the whole year, or we're going to pay you a lump for, say, adjuvant cancer treatment for a newly diagnosed breast cancer patient. We're in the middle of this transition, and every health system has a foot in each boat, and they have no idea how to work, because in the fee-for-service system, you make a lot of money by doing a lot of things, you know, operating a lot, giving a lot of tests and treatments. On the other system, the bundled payment or the capitation system, your incentive is to keep people healthy, keep them out of the hospital, out of the emergency room, away from specialists that they don't need, not use a lot of fancy tests that aren't beneficial, because that's how you can make money and you can keep the costs down. We are giving people mixed signals. So a large part of my time now is spent trying to get models on the side of bundle payments and others with very clear quality metrics that we can measure to make sure no one's stinting on care. So I've been working on cancer bundles. So one of the good advantages of working on cancer bundles is there are a lot of guidelines. This is the standard of care that the professional society, the oncologists, have agreed to. The National Comprehensive Cancer Network, NCCN, puts out guidelines. These are the preferred chemotherapies for this condition. Here's what you should do. And that provides an easy way both to create a bundle, but also to be sure, are you as a doctor doing these things and create quality metrics? And that shift, I believe, we're going to see a lot more of it over the next 5 or 7 years, but we have to accelerate it. And as I said in my remarks, one of my big regrets is that we didn't have more of that in the bill. And I'll tell you, one of the big problems is every insurer Medicare and others, they know how to pay fee for service, right? They know you send in a bill, and I can send you the check. They don't know how to pay bundles. They haven't constructed bundles. They don't know how to pay capitation and make sure that patients are getting all the quality of care. And it's not just restricted to Medicare, although Medicare has this problem. Shifting those payment systems, hundreds of millions, if not billions of dollars are necessary in investment in IT, and you have this chicken and egg problem. Well, if we don't shift the payment, why should I invest in the IT? And if I invest in the IT and we haven't shifted the payment, it's going to sit there and collect a lot of dust. So this is one of the things where it's going to be very difficult to, it's going to happen, but it's going to take some time and getting people to invest the right resources in creating the bundles and creating the capitation. I'm a big believer in these bundles of payments. So pay a doctor a set unit for all of the therapy. And again, I relate to cancer because I'm an oncologist, so I can figure out how it works there. Because that's the easiest way for them to get onto managing the bundle. We have the guidelines, as I say, and we can all agree on what should be done. So one of my projects is to work on that with a bunch of insurers, Medicare, oncologists. We think we have a viable plan, and we're continuing to work. We've been working on it for radiation. But a lot of people are working on different payment models, and it is a frustrating business at the moment. Again, I think by the end of the decade, we will have a lot of this structure in place, if not everywhere, in many leading parts of the country.
So it's interesting because I think everyone kind of can get behind the idea of like we need to have Medicare and Medicaid not just be ATM machines, right? Like go up, you get paid, you get paid, and you need value. But when push comes to shove and we start talking about what gets covered and the R word comes up. And by that I don't mean Republicans, I mean rationing, right?
Yep.
And so you've long been a proponent of cost consciousness in terms of physicians treating individual patients. And I think most healthcare providers actually agree that there's waste, commonly 30%. No one will admit to contributing to that waste.
Of course.
It's
someone else.
Yeah, exactly. There's waste, but we're all Lake Wobegon here. And actually, as patients, even though a lot of us recognize that the way we're using healthcare can bankrupt our economy, we still want that MRI. Like, how do you resolve this tension between kind of the individual patient and kind of looking at, even if you have quality metrics that are on a population level, how do you reconcile that tension?
I actually think this is a much less of a tension than most people. And the reason I think that is $3 trillion. We spend so much more than every other developed country on healthcare. Now, someone will say, well, they ration care in Canada. Well, look, the Swiss spend, somewhere between 11 and 12% of GDP on healthcare. No one goes around and saying, in Switzerland, they really ration care. You got to wait in line for heart procedures. You got to wait in line for cataract. Just not true. We could do much, much better. Right? A lot of what we have are two big problems. We have very expensive per unit costs. So we have a lot of excessive costs when we deliver, say, an MRI or a surgical procedure. Much more expensive in the United States. Mm-hmm. Now, I'll just tell you, one reason is we don't tend to run our MRI machines 18 hours a day, even though they cost millions of dollars to install. If you did that, right, you could reduce the price per unit a lot. Our hospitals haven't gone through lean process improvement and taken out a lot of costs. Hospitals that have done that in this country have saved tens and hundreds of millions of dollars. The Denver Health System went through lean, took out $160 million in 5 years. As I mentioned, this Dean Clinic in Madison, I visited them. They took out $70 million in 4 years. Lots and lots of savings there because we can reduce substantially the per unit cost of delivering things. And then there are things that we do, the 30%, whatever your number is, of unnecessary stuff. And again, I'm a cancer doc. Let me just give you the cancer examples. Last week, we held a meeting at Penn with lots of payers, lots of radiation oncologists. There's two areas, big areas in radiation oncology, where we simply waste a lot of resources. So women with breast cancer typically will get a lumpectomy and then radiation treatment and chemotherapy for early stage breast cancer. Now the tradition has been 7 weeks of radiation, 33, 34 fractions each day. Well, we have a number of randomized trials with many years, more than a decade of follow-up, showing you can give 3 weeks of treatment, 15, the same in terms of recurrence, clinically the same in terms of survival, and cosmetic looks just the same. When you look at American doctors, 80% of women are not getting this shorter course. Why? Well, I don't want to cast aspersions on my radiation oncology colleagues, but you get paid a lot more for the 7 because you get paid per time that you give radiation. And if you're giving only 15 days, you're getting paid, about 2/3 of giving the 7-week treatment. You don't have to be crazy to say, well, let's change that financial incentive and we can reduce costs at no clinical harm, no need to ration care. And I could give you lots of other examples. Again, many, many cases, my oncology friends will say, every woman with early stage breast cancer now comes to me with an MRI of the breast. Completely not indicated, no guideline suggests it. Thousands of dollars flushed down the toilet. And we could go on and on. Every specialty has its examples. So before we talk about the R word, let's do lots of other stuff to get rid of unnecessary care. And by the way, this isn't simply unnecessary in some way. It's not every medical procedure. Every medical procedure has some risks and some harms. You get that extra CT scan, got a lot of radiation there, We know that across the population that causes cancer. Not a good idea, right? Everything. It's not extra, it's not a freebie. They have risks to it, and they have complications. And we shouldn't be doing that. Let's talk about that first. Let's have every hospital and go through a lean process improvement. And then we can see where we're at. But again, there are multiple, as you mentioned, multiple estimates from McKinsey, from the Institute of Medicine, from Thomson Reuters, from a number of economists saying $700 billion of waste and unnecessary stuff in the American healthcare system. $700 billion. All right. We got plenty of things to do before we have to get to the R word.
So I have 3 questions that actually are about things that we can do before we get to the R word, and it's about actually pharmaceutical companies.
Yeah.
And so,
Inevitable.
as I think a lot of people know that there's actually a provision in Medicare Part D that prohibits the government from negotiating for drug prices.
It's
right,
not in
under
Part D, but
Part
it's,
D.
yes.
It's not in Part D? Hello?
Yeah.
There you go. So basically, some of the questions are, when will we see Medicare start to negotiate with pharma companies on drug prices? And then particularly with HCV meds being front and center on the news so much, will things change with these kind of test cases?
So let me make a few points. I don't think we're going to see Medicare price negotiation, but things could get sticky. Let's go back for a second. If you look at the $3 trillion that we spend on healthcare, I don't want to ask you, I don't want to embarrass anyone as to what proportion goes to drug companies. The public thinks it's a huge amount. A third of that $3 trillion, about $1 trillion, okay, goes to hospitals. They're the biggest consumer of healthcare costs in the country. The second biggest, doctors and offices. That's another 21, 22%, $600 billion. Drugs in the American system are 10%, maybe 12% of the total spend. And we've been spending at that level for a long time. Now, over the last decade, we have substantially increased our use of generics. We're now over 80% generics in the market. a large reason is the Medicare Part D, because a lot of the pharmaceutical benefit managers that offer Part D have really insisted on giving Medicare patients generics where they were clinically equivalent. So I think we need to put the whole drug thing in context. They are a big cost that we see as the public. Having said that, it's quite clear that these very large costs for drugs are outraging the public. Now, I think we need to at least divide those high costs into two buckets. One bucket is many of these cancer drugs that are $100,000, $125,000 for, 6 weeks of extended life, 2 months of extended life. That, I think, has a lot of people scratching their head. It's like, is that real value? The benefit doesn't seem very high, and the cost seems really high. Now, if they cured people, we'd be in a different equation, right? Then it's like, well, if you're paying $100,000 and you're curing someone from cancer, that's probably a very reasonable arrangement. And that's the second bucket, which is, we do have a big controversy about a drug where it's $1,000 a pill, but let's flip it around. $84,000 to cure hepatitis C. Well, is that really so outrageous? Let's step back for a second. You're curing hepatitis C. Some patients end up with, liver failure, cancer. Is $84,000 too much to spend for a drug to cure that disease? We spend $250,000 for a liver transplant to cure people. So I know that people are really concerned about the hepatitis C drug, not actually because of the $84,000 in my opinion, just because so many millions of people have it that it's going to be a big, big hit to the system. And I think there's also this worry that Gilead has gotten out with its drug. We know that there are other drugs coming behind that promise to be cheaper, the Merck drug and others. And it's not clear we need to treat everyone with the most expensive drug that's first out of the box, because many of these people are not having real symptoms from their hepatitis C. So we could rearrange things to wait for cheaper drugs. But I do think we need to differentiate in this big specialty, high-cost drug space, ones that are really, really beneficial and ones where, you scratch your head and say, what's the big benefit here? It seems to me it's those where you want to ask, what's the big benefit that we're anxious about? Now, I'll confess to you, I don't have the solution. I've been thinking hard about what we do about these very high-cost drugs. I don't have a solution, and I do think most people believe it's not going to go on. Exactly how the whole thing falls apart and what the replacement policy is, I haven't seen the person with that crystal ball, and I'm not prepared yet to say. But I do think we're at an unstable moment, and I think most of the drug companies know we're at an unstable. And by the way, stock analysts think we're at an unstable moment, and they're probably pretty good predictors.
So I have 3 questions about another area that's been posited as a potential savings for, overspending. Back in 2009, you were given the moniker Dr. Death by Sarah Palin, great honor, saying that you advocated death panels based on the proposal to actually pay doctors for spending time discussing end-of-life issues. As a primary care doc, I know how critical and how time-consuming those are. How likely is it this is going to be back on the table? Advanced care planning, end-of-life discussions. How do we change the frame for that?
So it is the case that in 2009, Sarah Palin, Michelle Bachmann, and a number of people came after me saying that I wanted to end the lives of a lot of elderly people, that I didn't want to give them medications. That's where death panels came from. And it really started, and there was never a provision written in the bill. We were thinking about, well, if you wanted to improve end-of-life care in this country, not to save money, just improve the care, because most people are, we don't think we're doing a great job. I mean, even if we're doing a better job than we were in the 80s, it's still not where it needs to be. Couldn't there be things that we could do to fix the system, or at least push it along in the right direction? And so some of the ideas we came up with, well, maybe we should, as Dr. Chen mentioned, give a one-time payment to doctors to have this discussion about end-of-life care with patients. It is time-consuming discussion, emotionally grueling, but it has to be started. And it's something that, naturally doctors put off because it is time-consuming and emotionally grueling. Could we incentivize having that discussion? We had other ideas. Maybe we should have every hospital that takes care of Medicare patients have a palliative care service so that they can actually provide palliative care to patients who want it and be assured that if patients went home, they got palliative care so that they could actually be at home, comfortable, and with their family. So these were some of the ideas. None of it crazy. Here is the ironic part of that discussion. Sarah Palin had a 30 days in Alaska where she was urging everyone to fill out an advance directive. Johnny Isakson, Republican senator from Georgia, had introduced a bill, not too dissimilar from this, to incentivize doctors on Medicare to have that discussion. As my brother, the politician, would say, they were for it before they were against it. And they were against it only because they thought they could attack and undermine the Affordable Care Act through this. All bunk. Now, again, these were ideas. They were never written down as provisions of the bill. I don't know that we're going to have another piece of legislation in the near term on health care where some of these ideas could go in. Nonetheless, there are many groups, and ironically enough, most of the American public actually want these kind of changes to improve their discussions. And again, this isn't government takeover. This is government facilitating the discussion between a doctor and a patient, which is where everyone believes it should happen. I mean, the other reason I got called Dr. Death is I said, I was for euthanasia, despite the fact that I have 20 plus years of writing that I don't think it should be legalized. The facts never mattered here. It was pure rhetoric to try to undermine the Affordable Care Act. And by the way, they know what they're doing, because if you look at polls, still to this day, there's something like 30% of the American public think death panel somewhere hidden in that bill. I can assure you, I've read all 906 pages, not in there that I can see. I don't even know that the word death is in there, to be honest.
So I apologize up front for I may just give you these questions so you can actually have some really great and thought-provoking questions, but I'm just going to start to wrap up. But just to your point, so at the end of 2010, the Kaiser Family Foundation did a survey where they asked Americans 10 true-false questions. Less than 1% got all 10 questions right. And then current polls still show that there are huge gaps in understanding around the ACA. And as you say, most people still think, or many people still think they're death panels in the law. So 2 questions. What could the administration have done better on the PR and administration front? And then for the layperson who wants to stay abreast of this, many of whom are in this room, besides reading your book, after reading your book, where should they go to keep up with this stuff?
Well, I do detail in the book some of the communication flaws in both during the campaign to try to get the Affordable Care Act passed and in the trying to spread the word. The administration did not do a good job. I don't think there's anyone who thinks that a good job was done. And in particular, August 2009, when a lot of congressmen and senators went home and got pummeled in the town meetings, was a terrible moment. We did not do a very good job of arming them with talking points, trying to be able to explain the Affordable Care Act. I think part of the problem, my own view, was that we should have found 50, 100 doctors who were supportive and articulate, put them in white coats with stethoscopes, find 50 or 100 nurses, put them in white coats and stethoscopes, and let them out all across the country. I'm not joking. People trust doctors and nurses. They need an explanation. I think people are very eager to get an explanation, and we just didn't do it. Is it impossible? I hope my book and I hope my speeches show it's not impossible. It's very much possible, but you do have to organize it, and you do have to explain it, and you can't just rely on the president to do that. It has to be done constantly over and over again. I think it was Richard Nixon who said, you know, you say something once, you say something twice, you say it 7, 8 times, you're sick of it, they're just beginning to hear it. And this is a complicated issue, and people have to hear it over and over again. So where would I go to, well, a very good site, and I don't want to just plug one place, but the Kaiser Family Foundation has a really superb, nonpartisan site that curates a lot of information about health care reform and the Affordable Care Act. I think if you want background, I will plug my book because I do try to work and write for a lay audience to try to give the background as well as what's in the Affordable Care Act and what it means for most people and what the future likely portends. But this is going to be a dynamic area. Things are going to change, and to keep up, I think, is very important. After all, this is a very large part of all of our lives. It's the American healthcare system. It's 1 out of every $6, and all of us at some point are going to intersect with it, or our loved ones are going to intersect with it, and we do have a big stake in it working well.
We are out of time. I will ask you one last question, which is, what words of wisdom or advice would you give to Obama's brand new Secretary of Health and Human Services, Sylvia Burwell?
Well, I think she's got to get the exchanges, focus on them, and make sure it's running as well as possible, and that it's constantly improving, that it really has this constant improvement mentality. And then I think she's got to focus heavily on cost control and this payment change and transform the system. And you have to have payment change to transform the system. And those, if I were focusing on it, those would be 2 of the big issues that I would have. And I'd also, by the way, have a goal, a very explicit goal, to have bring healthcare inflation down to the growth of the economy by 2020, because that is going to be key to the well-being of everyone in the United States and really getting the economy turbocharged.
Many thanks to Dr. Ezekiel Emanuel. Dr. Ezekiel Emanuel, Vice Provost for Global Initiatives and Chair of the Department of Medical Ethics and Health Policy at the University of Pennsylvania, and author of the new book, Reinventing American Healthcare. We also want to thank our audiences here on radio, television, and the internet. I'm Dr. Alice Chen, and now this meeting of the Commonwealth Club of California, the place where you're in the know, is adjourned.